Good morning, all. I'll be presenting a 36-year-old unmarried woman with pain abdomen for 4 months with previous history of abdominal surgery. This is a laparoscopic scar which is seen in the right lower abdomen as well as in the supraumbilical region. This is a T2 axial image in this patient in which we are able to see multiple T2 hyperintense mass lesions which are studded within the peritoneal cavity with similar appearing mass lesion within the uterus. This is the T2 axial images of the same patient. Here we are able to see the typical whorled appearance of the extrauterine fibroid, which mimics the signal characteristic of the posterior myometrial fibroid here. There are similar appearing lesions which are also seen in the anti-abdominal cavity, anti-abdominal wall, as well as in the prevesical space. The left ovary appears normal here and it is well visualized apart from the mass lesion. The right ovary is also seen here and that is also seen separately from the mass lesion. Here we are able to see the broad ligament fibroid which is anterior to the right ovarian mass lesion. This is the T2 sagittal images. Again, similar lesions are well appreciated attached to the anti-abdominal wall with a compression of the urinary bladder. This is two spot images I have taken. Here we can see all the anti-abdominal wall fibroids which are seen attached to the anti-abdominal wall in the prevesical space, and the urinary bladder is distorted between the uterine fibroid as well as in the pelvic peritoneal fibroids. There are similar appearing lesions which are also seen on the pelvic peritoneum here with minimal amount of ascites. This is a coronal images. We are able to see the similar findings with multiple fibroids and phlovoids which are seen in the both sides of the pelvic cavity. T1 axial images, again few foci of hemorrhages are seen within the mass lesion with better appreciated phlovoids. This is a diffusion sequence and stir sequence which shows restricted diffusion within the fibroids. Stir images confirms the similar findings which were already observed. So to summarize, there are multiple T2 hyperintense mass lesions within the uterus and extrauterine location, namely the broad ligament, pelvic peritoneum, anterior abdominal wall, rectus sheath, prevesical space with few T1 hyperintense areas of hemorrhage in it. T2 hyperintense phlovoids were also seen within the bilateral uterine arteries. These fibroids were showing mass effect in the form of compression of the urinary bladder and bowel loops. Bilateral ovaries and endometrium were normal, minimal ascites, and no omental kicking. So the diagnosis in this patient is disseminated peritoneal leiomyomatosis. So this is the ultrasound image in the same patient in which we are able to see similar lesions which are seen started in the anti-abdominal wall. This is better appreciated in the high frequency probe. Here we are able to see similar appearing lesions which are seen in the fat and in the anti-abdominal wall. Here we are able to see those. So the differential diagnosis for disseminated peritoneal leiomyomatosis is carcinomatosis. How to differentiate? If there is significant ascites, omental caking, liver surface or parenchymal deposits, then it favors disseminated peritoneal carcinomatosis. The other tumors which can have similar appearance are desmoid tumor, lymphoma, mesothelioma, and tuberculosis. But in this patient, the appearance of similar imaging findings within the uterine cavity, uterus, helps in differentiating that this is a disseminated peritoneal leiomyomatosis rather than the rest of the differential diagnosis which has been put here. Management: this is a patient unmarried, 3 previous myomectomies, now has again presented with diffuse peritoneal leiomyomatosis. Now options for her are hysterectomy, uterine artery embolization, and medical management. As far as hysterectomy is concerned, she is unmarried and she has not completed her family. So hysterectomy with surgical excision of peritoneal myomas was not an option at this point of time after 3 previous myomectomies. So she opted for uterine artery embolization with peritoneal leiomyoma feeder embolization. Coming to why not just medical management, yeah, GnRH analogs can be used, but they ideally use for a short period of time, because for a long period of time once they are used, there is a significant drop in bone densities in women who are using it for more than 6 months. Second thing is once you stop using it, the fibroids start growing back in size. So in our patient, we did an inferior vesicular artery feeder embolization. I'll just show the images. Yeah, here we are able to see this is the catheter into the inferior vesicular artery. This is the inferior vesicular artery which is seen here. This is the feeder which is going and supplying the fibroid. This is the tumoral blush which we are able to see with it. So once we saw it, we advanced the microcatheter. This is a microcatheter which is being pushed into the superior feeder, and through it what we are seeing is a microcatheter which is taken. The microcatheter which is taken into the feeder, and then we took a diagnostic angio. Here we are able to see this is a feeder with active extravasation of contrast within the endometrial cavity. So this was a powerful injection, so there was active extravasation. So I immediately plugged the entire artery with glue embolization. So this is the glue which is injected into the inferior vesicular artery as well as feeder. Apart from the inferior vesicular artery feeder, the left uterine artery embolization was done. This is pre-embolization and this is post-embolization. Post-embolization, there is complete knockoff of the supply from the left uterine artery. This is the right uterine artery. Again, multiple feeders from the right uterine artery. Here we are able to see the blush very clearly. So post-embolization, there was complete cutoff of the right uterine artery. So I'll discuss about only four important things. What is the classification of fibroid? Because there were multiple classification. I just wanted to focus on two classification which will be of clinical use to us. One is histopathological classification and another is location based. The importance of T2 hyperintensity in fibroid and what are the imaging findings that we look for in patient with the uterine artery embolization plan. And lastly about diffuse peritoneal leiomyomatosis. Fibroid classification, the standard histopathological classification divides us into a benign entity or a malignant entity on the two extremes, and then there are intermediate variants which can be mitotic activity, cellular, atypical, and stump. The cellular variant is T2 hyperintense, which means it will do extremely well to uterine artery embolization. The second important things about leiomyoma variants is these variants, if documented, should be followed up sequentially with ultrasound or MRI every 6 months to 1 year. Second thing is fibroid degeneration. When we talk about fibroid degeneration, these are varied degeneration which we routinely see in our clinical practice. In hyaline degeneration, there is T2 hyperintensity which is seen. In red degeneration, there is a peripheral T1 hyperintensity which is seen. Cystic and myxoid degeneration, both of them will be T2 hyperintense. Whereas in post-contrast, cystic degeneration will not show any enhancement, whereas myxoid degeneration will show delayed post-contrast enhancement. Then there's a fifth entity called fatty degeneration in which there is fat deposition within the fibroid. So whenever we talk about a T2 hyperintense fibroid, it means either we are talking about the intermediate cellular variant of fibroid or one of the degenerative variants of the fibroid. The second classification that is of use is based on growth patterns. The usual growth pattern that we see is submucosal, intramural, or subserosal. The unusual growth patterns are the one which are listed on the here. That is, it can either be a diffuse peritoneal leiomyomatosis, metastasizing leiomayomas, parasitic fibroids, intravenous fibroids, or retroperitoneal. Sorry. Intravenous leiomyoma, here we are able to see a huge mass lesion which is extending till the level of the atrium. Diffuse peritoneal leioma, as in our case, will be a differential for peritoneal carcinomatosis. And parasitic leiomyoma is a leiomyoma which got separated from the myometrium, and it is now taking its separate blood supply and it is adjacent to the uterus. Most common parasitic leiomyomas will be the fibroids from the broad ligament as well as the fibroids at the urethra. Twisting and narrowing of the pedicle, which will lead to accessory procedures. But now it has been clearly proved that if the pedicle, this is the pedicle of the subserosal pediculated, this is a large subserosal pediculated fibroid. Here we are able to see the pedicle from here to here. This is more than 2 centimeter. There is less chance of this particular fibroid to get distorted. Second thing is submucosal fibroid should not be there. No, again that school of concept is also changed. Now what they say is you take the I divided by D ratio. That is calculate the sum of the lengths of the submucosal component of it, the maximum distance of the fibroid. If I divided by D is more than 50%, there is a chance that the submucosal fibroids after uterine artery embolization will become intracavitary in nature and will fall into the endometrial cavity. And in such a case, what happens is they need to go additional hysteroscopic procedures, which are basically OP procedures. In the OP procedure, these intracavitary fibroids will be removed from the endometrial cavity. Third thing is adenomyosis. Here also we are able to see that there is an adenomyoma in a setting of multiple leiomyoma. So these leiomyomas will respond well to uterine artery embolization, 90% success rate. This adenomyoma is just 70% success rate. So this also has to be put forth to the patient. Cervical fibroids do not do well because they have a separate feeder from the interiliac artery, or they are a separate blood supply from the uterine artery. Coming to T2 hyperintensity and non-viability, T2 hyperintense cellular fibroids do well to uterine artery embolization, whereas non-viable, that is on post-contrast sequences, if there is no enhancement within the fibroid, then obviously they are not going to benefit because we are just going to knock off the blood supply to the uterus. So those fibroids which show inter post-contrast enhancement will do extremely well to uterine artery. This is a checklist which I put forth. You can go through. So the teaching points of diffuse peritoneal leiomyomatosis, whenever there is a patient who has multiple hypoechoic nodules or hyperintense nodules, go through the history of surgery or myomectomy. Second thing is, if in this particular patient, if the signal lesion in the uterus, the mass lesion is the same as the mass lesion which is seen in the pelvic peritoneal cavity, then it becomes diagnostic. It even helps us in ruling out malignancy and tuberculosis. Provided we have a lesion which is seen in the uterus. In case if we do not see a lesion within the uterus, we have encountered such cases in which there would be just a single mass lesion which would be seen in the right side abdomen, but it will be typically looking like a fibroid. If you want to rule out, either you can go ahead and do a biopsy, or you can just do a FDG PET in which peritoneal carcinomatous will show uptake, whereas leiomyomas won't take uptake. The last and most important thing is it is mandatory to do to wash out these fibroids closely, because there is a high chance of recurrence and sarcomatous changes. These are various articles which are referred to. Thank you.